Good morning. This is Dr. Duke Majan with the team here at Duke Spine Institute. We're getting ready to start our first surgery of the day. It is now January 19th, 2023. We have 5 surgeries scheduled for today. Our first patient comes to us from Georgia, and he injured his back 30 years ago with a exploding tire. He has 2 areas of injury. He has the thoracolumbar junction, which is going to be T12-L1, L1, L2, 2 discs that are damaged with herniation, degenerative disc disease, stenosis right here. And he also has 2 discs that are injured down lower in his L4-5, L5-S1. Now, one of the things that's unique about him, if you look at his MRI at the bottom there, it will show you that he has an unusual disc in the sacrum, okay? And that disc is called the pseudo disc or fake disc because it's not a real disc, but it looks like a disc, and it's important to take it into consideration because in the operating room we use an x-ray machine, but in the MRI scanner, it's an MRI, it's a different modality of imaging, so the disc will look different. So on an MRI, it's pretty apparent there's a disc down there at S1, S2. Some radiologists would call that a L5-S1 disc. I'm calling it an S1, S2 disc. And it doesn't really matter what you call it, S1, S2 or L5-S1. What matters is that you operate on the right discs. So for purposes of this surgery, we're going to call that bottom disc, the one that's really not really a disc and it looks pretty much normal within the 2 bones at the bottom, that's going to be called an S1, S2 disc. Therefore, the disc above will be the L5-S1, and the one above that is L4-5. So we're actually operating on what I'm calling L4-5, L5-S1, but other radiologists may call that the S1, L3-4, L4-5. Okay, so just a difference in nomenclature. The most important thing is we just operate on the right discs. All right, we're going to start by accessing T12-L1, L1, L2. I can see on the x-ray the 2 discs that need to be fixed, and we're going to target them right now. And we're supposed to go from the left side at T12-L1 and L1, L2. Shot. All right. We're going to try to do this through 1 incision. Shot. Yeah. So you can see right in front of the needle is the L1, L2. Okay. Everyone in agreement? Shot. All right. And I could feel the facet joints, so I need to get around them. Now this patient's had pain on and off for 30 years, but really bad over the last shot. Let's get an AP, see where we are. Maybe a little too lateral. He's had pain on and off for 30 years, but over the last 2 years it's gotten unbearable for him. Like most patients with chronic back pain, good. So we're medial, which is good. I just need to be a little more lateral. So we're going to do this disc and the one above. That's the T12-L1. You can see the ribs. Show the ribs of T12. So the way you know where T12 is, you see the rib there? It attaches to the pedicle of T12. Show us the pedicle. There you go. So we know that that body, vertebral body, is 12. Show them 12. And that the disc there below it is 12-1, meaning 12-L1. That's below is the L1 vertebral body. Then the L1-2 disc, which we're operating on, and then the L2 vertebral body. So as a matter of fact, if you use the ribs, I've chosen the right nomenclature for this. However, if you look at the radiologist report, they chose a different nomenclature. All right. So far, so good. We're heading into this bad disc shot. Just have to get around these facet joints. So I'm gradually, carefully moving more lateral every time. There we go. As you can see, I'm getting around them. And there we go. And you want to just hug the facet. AP, how's he doing? Reliable?
Hello, my friend. Hi. Can you open your eyes? Are you having any pain? Yes. Are you having any pain anywhere, sir? You okay?
Looks perfect.
Oh, he's okay.
So we're just lateral to the fecal sac, which contains the spinal cord and nerve roots. Are you comfortable?
Yes.
Just lay still, all right? Shot? Yeah. So he's a little tight. His muscles are tight. Now, let's see if we can get to the other disc. Above. I'm going to change the orientation of my incision. Any pain?
Yes.
A little bit?
Yes.
All right. Let's see if we can give him a little more num-num. Yep. So remember, we're starting with the top two bad discs. That's my phone. Do you mind checking that for me in the hallway? Yeah. The patients need to be awake in the beginning of these surgeries because, who is it?
It was an unknown number, and they said they had the wrong number when I answered. I answered as your phone.
So we're fixing 4 discs today. We're fixing the T12-L1, L1, L2, which we're talking about and accessing right now. And then we're going to go and fix as well the L4-5, L5-S1. Shot? All right. I may have to make a separate incision for the higher disc here if I can't get to it this way. I'm thinking I'm going to have to do that. So I've already numbed up the skin. You okay? Everything's going well, all right? I know you've watched some of these surgeries before, so you know what it involves. Shot? How many of these surgeries have you watched? Huh?
He just said
A few, all right. So, Henry, let's show our audience what exactly, why do herniated discs cause back pain in the first place? Why do degenerated disc, herniated discs, what is it about them that hurts so much?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. So far we've been able to access the top two discs perfectly, and now we're going for the bottom two discs. And he's doing fantastic. He's really helping me a lot by just communicating with us and staying still. We haven't done our discograms yet, so remember, the diagnosis of the source of his back pain is a clinical diagnosis. Patients with back pain, their diagnosis as to what's causing it is so important, because if you don't make the right diagnosis, you're not going to get the right treatment. And in his case, as in most people's, it is a disc injury that's causing the back pain. Now, this is something, I hate to say this, but it's something the insurance companies don't want you to know. Why? Well, because disc injuries are fixable with this procedure, Duke laser disc repair, and they cost money to fix. So insurance companies nowadays are just denying even MRIs just to look and see if there's a disc problem, knowing that people probably will have a disc problem and they will need surgery. Sean? They just don't want to pay for the surgery. But in the end, it's not about whether the insurance companies pay for your surgery or not. It's about getting out of pain and having quality of life. And that's why we perform our surgeries. We're not beholden to the insurance companies. The insurance companies, we recognized many years ago, obstruct good medical care. They don't facilitate it. So if people want good medical care, sometimes they're going to have to fight their insurance companies to get it. All right, we're going to go with an AP view, which is a front-back view. I'm happy with the lateral view. We're right at the foramen. The way the Duke laser disc repair is done is we don't go through the bones and ligaments like other surgeons. That's perfect. In the back of the spine, okay? Most spine surgeons, pretty much almost every spine surgeon out there in 2022, 2023, because we're starting 23, they all come to the spine this way. We call it translaminar. They go through the bones and ligaments. They have to rip them out, remove them, and that is a destructive process. Instead of doing that, we come from the side. Let's go ahead and show our audience the difference between a microdiscectomy, laminectomy, so they can understand that procedure and how destructive it is.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. So you've had a chance to see what a microdiscectomy is, AP. And microdiscectomies are destructive surgeries. They ruin your spine with the surgery. They basically, your problem is a herniated disc, all right? And the surgeon, to get to the herniated disc, has to remove ligaments, bones, muscles, and it causes scar tissue and bleeding. The Duke laser disc repair, we don't remove any muscles, bones, or ligaments. We leave it all alone. All we're doing is gently separating the muscle fibers with a skinny little tool, a tube. And so when we leave, the muscles are normal. But every other spine surgery, laminectomy, discectomy, it destroys your spine in order to get to the herniation. All right, he's doing fantastic. I could feel the herniation right here in the foramen. His spine is very anterior. Okay, what does that mean? His spine is very far forward. And I can tell you why. Look here. Can you see this, Henry?
Yes, we do.
These needles normally don't go all the way to the skin. The fact they're all the way to the skin tells me his spine is very far forward in his body. All right. We have accessed the 4 disc areas we're fixing. And now we want to know, was I right? Are they indeed the cause of his back pain? Because the diagnosis, as I said earlier to you, is a clinical diagnosis. Basically, I examine the patient, they show me where their pain is, and I look at the MRI and I see what's going on there. And most of the time it's a herniated disc, bulging disc, annular tear, degenerated disc, some disc problem. And they're all the same, by the way. They're just different stages of degeneration. But the injury is the same. The mechanism of pain is the same. All right, are you comfortable?
How are you doing?
Yes.
Yes, okay.
All right, we're almost going to put you to sleep and we'll be done, all right? But we need your help. Just lay still. You're doing great. So our patient's awake so that we can get some information. That's the T12-L1. Here's, L1, L2, okay? Are you comfy?
Yes.
Now, was it your upper back pain that was the worst or your lower back pain? Upper. All right. Are you feeling any pain right now? Oh, you want to start lower? Okay. All right, good. How bad is that on a scale of 1 to 10? What's the highest it goes?
8 to 10.
So it's a 10. We count the highest number. I love the range. Jordan, show the audience on the discogram where the tear is in the back of the disc, where the herniation is. So the black dye is the herniation. It's inside the tear. There shouldn't be a tear there. Okay, show them the herniation in the foramen. You see the outline there? No. In the foramen. That black dye? Yes, that. That little wisp of dye is the herniation. Is that better?
Yes.
All right. All right. So that was a at L4-5 was a 10 over 10. Is that where you get your back pain in the lower back?
Yes.
Concordant. Go ahead. How bad is that on a scale of 1 to 10? What's the highest? All right. 10 plus. All right. Is that where you typically get your back pain?
Yes.
So that's horrible pain this patient experiencing from both of these discs. And we call it stands for concordant. That means that's the kind of pain he gets every day in that area. He just doesn't get a 10 every day because he's basically taking it easy so he doesn't aggravate this herniation. But you see the full potential of these herniations. 10 out of 10 pain in worst case scenario. Is that better? Are you comfortable?
Yes.
All right, good. Just lay still, okay? We're almost done. We're going to put you to sleep. How bad is that on a scale of 1 to 10? 10. Yeah. Is that where you get that upper back pain?
Yes.
And how many years have you had that pain?
About a year, 4 months.
So before that, you never had pain there?
No, not at all.
Not once?
No.
All right. How bad is that on a scale of 1 to 10?
9, 10.
10. So 10 out of 10 pain. Is that where you get your upper back pain?
It is.
You've been very helpful. You've been wonderful. We're going to put you to sleep. When you wake up, we will be done with your surgery and those pains will be gone for the rest of your life. That's what I expect, all right? I want you to count from 1 to 100 in Chinese.
Okay, absolutely.
Go ahead.
No.
That's all right. Keep going. You're doing good. All right, switch over to English.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10,
Keep going.
12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23,
All right, so we're about to start the laser surgery.
26,
Keep going, you're doing great.
29,
So,
32, 33, 34, 35,
num num.
37, 38,
The reason why we have our patients count is that way we know when they go to sleep. Because right now our anesthesiologist is giving him sleepy medicine in his vein. We just would like to know when he's asleep. It kind of gives us an idea of, okay, we're there. That's where we need to be, and we've given enough, and then we can monitor. Because every human being requires a different amount of sleeping medicine. Some require more than others. Now I've had to make 2 incisions because I couldn't get to the 2 discs with 1 incision up top. But I think this will work right here. We should be able to do these 2 Band-Aid incisions and get this fixed. I'm going to remove the spinal needle shot. I'm going to leave the guide wire. The guide wire will guide our surgery. Next, dilator will come down the guide wire shot. And we're going to use this dilator to basically spread the tissues so we can get a little tube in there. Let's bring the tube up, shot. So, this is the tube that we're going to do the whole surgery with. You see this here?
Yes, we do.
That's minimally invasive surgery, folks. And the reason we could do it with this minimally invasive tube is because we do it endoscopically. And an endoscope is a special tool, I'll show you in a minute, that allows us to look inside with a tiny little incision. Most people know it as arthroscopic surgery. And as you know, surgery on the human body over the years has evolved to become less invasive. This is an endoscopic surgery done with a 1 port called a uniportal. You hear all these guys over in Asia doing biportal. That means they're doing 2 incisions or 2 ports. More invasive. We don't want more invasive, we want the least invasive. And that's what we offer at Duke Spine. So now, the only damage to his entire body we're doing is the skin incision, which is nothing. It's going to heal in a week. The rest of this, below the surface, no scar tissue, no bleeding. We're basically spreading the tissues apart, gently, with this little dilator here. All right, use the x-ray shot. We're making our way down to this painful disc that's damaged. And specifically, we're going through the tear in the back of the disc. We're not actually making a new injury to the disc. We're going through an old injury. Is he asleep? All right. So because there's already an injury there, we're going through that tear in the disc, and that's how we're going to fix this disc. So people ask me, aren't you hurting the disc when you go in? The answer is no. The disc is already hurt. It's already injured right here. Shot. So we're going through an injury that's already there. All right, I'm going to bring the dilator a little bit further into the disc. He's feeling better now. I could feel the tension in the muscles relaxing as he goes to sleep. We want our patients relaxed so that their muscles aren't tightening up and pushing the bones together and squeezing the disc. Just lay still, you're doing great. Now you can't do this surgery without some type of anesthesia. And he is asleep, but it's a light sedation sleeping. A little bit more. That should be good. I know it looks brutal hammering this tube in, but believe it or not, it's the safest way to do it. If I'm pushing on it hard with my hands, it could actually slip. Did you get it or not?
Let me wet this.
So at this point, the tube and the dilator are stuck together because there's some herniated disc material in there. Let me see if I can loosen it a little bit. I don't want to go in any further because it's actually taking the dilator with it. Let me try. All right, go ahead. Take your time. Sometimes the disc material gets stuck between the tube and the dilator and wedges in there and makes the two of them, we call it a cold welding. They're not really welded together, but they're quote unquote welded together with some soft tissue. No?
The extractor is there.
Don't, no, stay back. Nope. Let's get the, we're gonna have to pull the whole thing back, unfortunately.
Like a entire thing?
Mm-hmm. How deep is he? We need him deep enough because otherwise his muscles are compressing this and keeping it from coming out. So wherever you feel is safe to keep him deep, let's try to bring the whole thing back. Shot? Yeah, it's coming back. So what we may have to do is take it out and reapply. All right, now let's see if we can advance the tube without advancing this. The dilator. I have a feeling it's just going to move together. Yeah, the whole thing is moving. Yep. So we're just going to have to put a guide wire and take it out. Unless you have a, you want to get a wrench,
The vice grip?
vice grip.
Can I have the vice grip, please?
Yeah. Yeah, the vice grip gives us a little better purchase on the dilator. The whole thing's moving. That's the problem. Just boy, Oscar, you're killing us. You don't know what a vice grip is? Where's blood pressure? We need to get the blood pressure down. Unreal. All right, let's go ahead and show the audience while we're working on this, what does the Duke laser disc repair actually do?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
You guys using lubricant on this stuff?
Yes, sir.
How come it's opened all the way? Huh? How come it's opened all the way?
Oh, when we clean it, we have to.
Then put it back after. You know? The OR is the wrong time to do that. Go ahead and put a,
Oscar,
yeah.
and then can I have another set of tubing just in case standby? They're working sleeves.
Huh? The whole thing? Yeah, we're gonna have to take the whole thing out.
You want to put a guide wire and then
Yeah.
Remove, sir?
Where's the guide wire? So we're gonna replace the guide wire because we have to take the whole thing out. We're unable to get it separated. Sean? All right, go ahead. Sean? Don't let the guide wire come out. You fix that. I'm gonna hold some pressure so we don't get any bleeding. So basically, look at, let me see it. So this disc material has managed to shove itself in between. Can you guys see this, Henry?
Yes, we can.
See the disc material there?
Yep.
Show them. Hold this.
Yes, sir.
You guys see the disc material? Turn it. Right there. Stuck between the two. That's what is keeping the tube from coming out. Here, show them.
Oh,
No, it's all right. Never mind. It's too late. Bang it the other way. Bang it the other way. Well, so much for starting early today. Is it coming?
yeah, I feel it.
Once you hold pressure here for a second. No, you should have it now. It should come without even having to use that.
Do you have another set?
What's wrong with that set?
No, stand by.
And nothing wrong with it. It's just got some schmutz in there. You have another guide wire? There we go. I got it out. Ah, boy. So, troubleshooting 101. Shot. That's why we record and live stream these, because, you know, being able to see how we solve problems is important for young surgeons who are wanting to do this stuff. Irrigation. There's still stuff in there. You see it?
Yeah.
See the little bit of disc material in there? You guys see that, Henry? In there?
Yes, we do.
Yeah,
Still there?
it's gone. Well, let's see if we can get this a little better this time. Shot. You always want to watch with x-rays. Shot. And make sure that everything is going the way it's supposed to. All right, that looks good. Now we can actually get to the surgery. Hey, why is our suction not on the tube? All right. So we're going to start the T12-L1, the top disc. And let's go ahead and show the audience a video of, I know we did it already, but since we had an intermission there, what does the Duke laser disc repair actually do? Inside the disc, by the way, look at all the granulation tissue, the pink stuff. That's a great picture. Maybe you just, let me just clean the lens real quick. All right, see the pink stuff, guys? I know it's a little blurry, I apologize for that. But let's see if I can make it better. All right, see all the pink tissue? That's the inflammatory tissue. We have it in our videos. The blue stuff is the dye we put in, the Duke Spine Institute dye that stains the herniation. It helps me see it to remove it. But the pink stuff is the granulation tissue. From inflammation, chronic inflammation. You only get that with really, actually you get granulation tissue with all inflammation, but you see a lot of it when you have chronic inflammation. And we're seeing inflammation here. That's what's causing his back pain, is the inflammation inside the annular tear. Most people don't know this, but I still distinctly remember being taught as a resident in neurosurgery, the most painful condition of the spine is something called discitis, where you have inflammation of the disc. And it's so funny because everyone says, we don't know what causes back pain. We don't know what causes back pain. And yet we know discitis causes back pain. Everyone knows that. So they know that an inflammation of the disc will cause horrible pain, the most painful back pain there is. Worse than a fracture. And yet the answer was right in front of their noses all this time. Every neurosurgeon knows discitis is severely painful. Yeah, we had a patient on Tuesday, we just did this week, who had an infection in his disc from having dirty surgery done elsewhere. Yeah, he's doing fantastic. He was from North Carolina. I think this patient's from North Carolina, right? Georgia, sorry. All right, look at the granulation tissue. That is, Henry, get a picture of that. That would be a good one for our paper, right there. And give that to Arias. Get a still.
Copy that.
All right, you can get a high quality picture, right?
Yes, sir.
Yeah. That will be for our thoracic paper. Arias, is he there?
No, he is not.
All right. Well, make sure he gets that digital file. I want the ones that I've told you to take pictures of. This happens to be a thoracic disc. So this can go on our thoracic paper. It's very important he gets that picture. I want that picture in there. I want to show the other doctors exactly what we're talking about when we talk about inflammatory tissue in the disc within the annulus.
We have a question.
Sure.
This comes from Doug Dean on YouTube.
Hi, Doug. Welcome to our broadcast.
And they asked, is using the laser less precise than the traditional method?
Really? Sorry, Doug. Obviously, I don't recognize your name. You're new. Hey, get a picture of this right here. See the granulation tissue right there? The pinkness? You know what? Let's take the exposure down one notch. One notch.
On the top.
I want you to get this still as well, Henry.
Yeah.
Come on, guys. Maybe one more. Let's see if that makes it better. There you go. So you can see the contrast a little better. Get that picture right there. Right there. All of these. Give a bunch of them. We'll pick the best one. How's the clarity? It's good, right? Henry,
Yes,
Henry.
the clarity is good. Yes.
All right, so getting back to George's question. George, that laser you're seeing right now is 1 millimeter. So the precision is 1 millimeter. All right? And there's no surgery instrument in neurosurgery that's 1 millimeter precision besides the laser. So that makes the laser the most precise instrument in neurosurgery. The most precise instrument in neurosurgery. I realize there's a lot of misinformation out there about lasers and back pain and surgery and shots and everything. There's millions of bits of misinformation that people have been led to believe, though it's false. And this is probably, lasers are not useful or dangerous. That's probably the most false thing in spine surgery today. There's the back of the disc. We are almost done at this disc, another 30 seconds. One nice thing about thoracic laser surgery, Duke laser disc repair, is the fact that the discs are smaller and they take less time. How did you like his Chinese counting?
I understand it.
Well, I understood it too. It's because I know Spanish pretty well. All right, just about done here. He's jumping around like a Mexican jumping bean, right? Anybody remember the old Mexican jumping beans when you were a kid? Hmm? No. No? You didn't know about Mexican jumping beans? They were the coolest thing in the world when I was a kid. When I was in my 5, 6, 7-year-old. If you had a Mexican jumping bean, you were like the coolest person at school. Of course, I didn't have one, but other people did. I got to see their Mexican jumping beans. What it is, it's a pod, like a seed pod of a tree. And it actually snaps and moves. I think there's a worm in it, a little caterpillar. All right, we're done here.
Lights on, please. Thank you.
All done. Let me just do a quick grab with see if there's any more herniation. Sorry. Where's the grabber? You're doing great, buddy. Just make sure I'm not leaving anything. Nope. All right.
All right. Lights on, please.
Scope off. So, Henry, let's show the audience the scope. You got the blood pressure back up again and you're causing bleeding for me. How many times do I got to tell you the same thing? Got to keep that blood pressure down. All right, Henry, you see this? Yeah, but it's at 132 again and we popped
Yes,
the
we do.
cork. Yeah, but that's when the cork popped. You guys see the scope?
Yes, we do.
All right, so today we're using a lumbar scope on the bottom thoracic disc because it's really more like a lumbar disc than a thoracic disc. I need the irrigation. We're putting a little antiseptic to prevent infection. We were talking about this the other day because we had a patient come in here who had an infection in his spine from surgery done elsewhere, and he was asking me, do you think this procedure could help him clear out the infection from his disc? And I said, absolutely. This is the very best surgery you can do to clear out an infection from your disc. Also, mostly to prevent an infection. But somebody else got to him before we did, and they did surgery on him up in Virginia. He ended up with an infection, and we came here and we cleared it out for him. And we were talking about, well, what do we do to prevent infections? And we went through a list of things, and just here in the operating room, we spend over $250 on things that prevent infections, okay? For example, this IA band right here, this material, it's from 3M, very expensive. That's a barrier to infection, okay? And then we use DuraPrep underneath that, where we paint the skin with a special chemical that prevents infection. We also have all these sterile drapes, which cost a lot of money, and they prevent infection. And we have all these sterile gowns and gloves. What would you say, Luis? I estimated 250 bucks in around there. Yeah, when you add up all the drapes, and then you got the antibiotics and the betadine and all the sterile barriers and stuff that we have, the autoclaving. It's probably more. It's probably more around 500 bucks a surgery. But other doctors, they cut corners, and they don't spend the money on the antibacterial, anti-infection techniques. Okay? Why? Because every dollar they spend is $1 less profit. And they're basically putting profits ahead of people's health. We see it all the time. That's why there's complications in spine surgery. Infections happens quite often. I think they're all basically avoidable. 99.9% of surgical site infections are avoidable. But they're only avoidable if you're going to do what's right for the patient. So even when I do fusions, oh, I already did? Yeah. All right, even when I do fusions, I still avoid infections because of our technique and what we do. We've done hundreds and hundreds of fusions here at Duke Spine in our surgery center, and we don't get infections. More? Yeah. And the reason we don't get infections is because we're very careful and we do all the right things. So, if you care about getting an infection and you don't want one, it's best that you go somewhere that's trustworthy and doesn't get infections. All right, any questions from our audience?
No current questions.
Okay, so we just completed a thoracic Duke laser disc repair. We're going now to L1, L2. I can feel the herniation right here against the tip of my dilator. So I'm going to have to push the herniation back into the disc, and we're going to take it out from inside the disc itself. Shot? All right. Have to aim up a little bit. Looking good. Shot. Beautiful. We'll take the guide wire out. Nice job, Luis. Way to anticipate. All right, we are now inside the disc. So we're going to bring the tube down. And once again, the entire surgery is done through this tube that we're about to put on right here. And to get the tube in, you have to use a dilator. We call this tubular surgery. And it's a tubular retractor, meaning it's retracting the soft tissues in a tubular fashion, as opposed to a blade retractor, which doesn't retract tubularly. A blade retractor just retracts on the sides, either left, right, or up, down. I think that's good. See if you can get it out. I think it's going to be another tough one. Better. So we didn't have to go off on a tangent trying to solve another cold welding situation. Surgy lube. Is it sterile? It's not a bad idea. But you know, most of the time it never happens. By the way, you guys see the incision that we did? It's 7 millimeters. That was for the T12-L1 disc. Now we're going to do the L1, L2 disc. And then we're going to, May not be a bad idea, Louis. I just worry about putting that on with sterility and all, because I don't think the outer packaging is sterile, and I don't trust the inside either. And I wouldn't want to introduce something that could potentially cause an infection. You know what I mean? It's not worth it. As a matter of fact, a little bit of irrigation is all you really need, you know, just enough water lubrication. All right.
What you can do is you can open it up from a sterile package and then you squirt it onto a sterile.
Yeah. I just don't feel comfortable switching up doing that. It's a good idea, but it's not worth the risk in my opinion. And then you got the Surgi lube on the equipment and you got to go sterilize it, and it's, you know, it's a different consistency, and it sticks a little bit. So are the machines going to be able to get it off? You know, probably, but I just don't want to introduce another variable. I think that the sticking of the tubes is so rare. I think what we can do is just put some water down there, some sterile water that we already have on the field. You know what I mean? So it slides. I think it happens more when they're dry, you know, when we first put them in, and then once they're wet, they don't really stick as much. So I think that's probably a good idea, just to squirt the inside of the tubular retractor with a little sterile saline that's already on the field.
You would squirt a surgeon's glove when they're tying it.
Yeah, that's right. It makes it, you know, less friction.
We have a question.
Of course, we'll take the question.
This comes from Colin Day on YouTube.
Hi, Colin. Thanks for joining us today in live surgery.
They ask, do certain types of post-surgery medications help with pain relief, i.e. less expensive versus more expensive? Thank you, doctor.
Yeah, great question. I'll do my best to answer you. Do certain types of post-operative pain medications help better or worse with pain? And is there a difference in the cost, I think is what he's asking. I don't know if I got the question right, but that's what I heard. Maybe I didn't. If I did not get it right, just resubmit it, maybe clarify it, and I'll do my best to answer. Yes, there's medications, folks, that are used during surgery and after surgery. And those medicines have dramatic differences in pricing. And what I found is that most doctors taking care of patients in their office or in a surgery center, they'll cut corners and they will give the patients the cheap medications that don't work as well. Okay, that's a universal truth, unfortunately, and it's a result of declining reimbursements. So basically, the insurance companies keep cutting our reimbursement every year, paying us less and less. And so when you're getting paid less and less, you gotta do something, right? Because it seems like it was loose, and I'm just tightening it. So, you know, if you're getting less money for your surgeries and you have a contract with the insurance company and it says you can't bill the patient, then where are you going to get the money from in order to cover the less payment from the insurance company but higher cost of supplies? They keep going up every year for us. And the answer is you either have to renegotiate with the insurance company and get more money, which they're not going to do. They don't negotiate. They're disgusting. They just say, take it or leave it. We're paying you less. Or you have to cut your costs somehow. So you go with cheaper things. Or you don't provide that thing for the patient. For example, you know, one of the things we do during surgery is we give a medicine for nausea. And what is that medicine? Scopolamine? Huh? Zofran and scopolamine. Those are expensive drugs. Very expensive. But we give it to our patients because we don't want our patients nausea and vomiting after surgery. Okay? Other places will just say, hey, you're going to have some nausea and vomiting. after your surgery because we're not going to spend the money. They're not going to tell you that. They lie to you. They say, oh, yeah, we're doing everything, but they're not, okay? And that's happening more and more. So as a consumer, you should be aware of these differences. As far as post-op pain medication, yeah, there's very expensive and there's less expensive. But the doctors usually don't care if it's medicine you're taking from the pharmacy because you're paying for it. They're not. So they'll give you whatever they think is best or whatever, you know, the drug rep that's the cutest come into their office. You know, they'll use those decisions to guide what they do for their patients, unfortunately. We don't let drug reps in our office, so we don't have to worry about that. We just do what's best for the patient. Now, it turns out with the laser surgery you're watching, there is no postoperative pain medication. In other words, you don't need narcotics or painkillers, powerful painkillers after the surgery because the surgery is so minimally invasive, the incision is 7 millimeters, a Band-Aid, that people's pain is gone by the next morning. They don't have postoperative pain that lasts for days or weeks or months like you do with open back surgery. So with our surgeries here, the postoperative pain medications are not as important. We ask people to take Tylenol for one night and then Robaxin, which is a muscle relaxer, and that's it. And they're usually very happy with that. They don't need anything else. We used to prescribe opioids for pain after the surgery because after all, it's spine surgery, right? And we would think, oh, it's got to be painful. But then what happened was the patients kept coming back and I would ask them, so did you use your pain medicine? And they said, no, we never took a pain pill. Never took a pain pill. And I kept hearing this over and over and over again. And I realized, well, then why are we writing them for pain pills if they're not using them? Number one, it's inconvenient to go to the pharmacy and get it, right? So what patient wants to go to the pharmacy to pick up a pill that they're not going to use? And then number two, why would they want to spend money on a pill they're not going to use? So it became my responsibility, my duty to my patients to basically change what we were doing because they don't know. They're going to go to the pharmacy and pick up the pills we recommend. So we stopped recommending pain pills. We stopped prescribing them. And patients have done fine. So this is one of the biggest difference between the laser surgery. By the way, that's the end plate, the bottom of the vertebral body right there, abutting the disc. You can see the left and right. That's going to be L1 and L2, since we're at the L1-2 disc. So one of those end plates will be L1, the other one will be L2. And we're just about done here with this disc, another few minutes and we'll be done. I hope I answered your question. I'm not sure if I did. I tried to. I don't know if I understood it properly, but
Colin replied back, he said, exactly what I was after. Thank you.
yeah, you're welcome. All right, this is the back of the disc. We're pretty much done. We've started inside the disc. We went through the tear. We pushed the herniation back in, and now I'm zapping it away with the laser. But yeah, we're just, oh, there's a piece of herniation. See that? Every one of those little blue things is a herniation. We are literally right below the nerve root that exits, and we're also lateral to the traversing root. For those of you who know what the traversing root is, it's a nerve root that's passing down to the next level. All right. All the herniation is gone. And what you're seeing there is the epidural space, a little bit of fat. That's all normal. It's normal to see fat in there. So the great news is this pain from this disc will be gone for the rest of his life after this surgery. This is the only surgery that takes back pain away and allows the discs to naturally heal and repair themselves. All right. We're going to move on next to the lumbar, L4-5, L5-S1. The bottom two bad discs. We're going to fix those next. Just want to amputate this piece of degenerated disc right here. You see how precise the laser is? Somebody was asking about how precise the laser is. Think about the laser fiber right there is 1 millimeter side to side. Okay? So what you're seeing here in the tube is the inside of the tube is about 5 millimeters, 5.5 millimeters. And you can almost see individual red blood cells. You can definitely see individual fat cells. Each one of those little crystalline light reflections is a fat cell. All right, I want to get this thing out and we're done. Grab her. Keep the questions coming. I enjoy answering them. That's what we're here for. We like to use this time to teach. See the fat, guys? That's just the tiniest amount of fat, but in the endoscope, it looks huge. That's because everything is magnified here. All right, now we're going to, again, use our antiseptic, which is betadine, to rinse the area and make sure there's no bacteria that survive in there. I don't expect that there's any bacteria, but we do this as a precautionary measure for every patient, because if somehow we did get bacteria in there, then the betadine would kill it. We've never had an infection with this surgery, 16 years. Not a single infection. All right, 2 down, 2 to go. I'm going to take this tube out. He's doing fantastic. Hemodynamically, he's stable. Thank you. Watch it, it's going up again. I'm going to switch over to the patient's right side next. Hold pressure. This would be a great time for questions. All right, we've completed the 2 upper discs, one the thoracic T12-L1, the other L1-L2. We're going to go down to the L4-5, L5-S1. Go ahead, get that. What's going on? Switching the pedal? Yeah, go ahead and get that down there. Absolutely not. We're not num-num people. Let's go, let's go. All right, so he wants some num-num. We'll do it. Okay, why is this laser out here? I don't want it coming off the field. You want me to start at 5-1? All right, let's get an X-ray picture. Beautiful. We'll put some num-num, don't worry. All right. Let's get some num-num. Num-num is just numbing medicine. Oh, it looks like it's clogged. Definitely clogged. You have another guide wire? So there's 2 ports on the dilator. One is for injecting medicine. The other one is for passing down the guide wire. Shot? Shot? So there we go. Broke through. There was just a little bit of disc material stuck in the other port. And I just had to clear it. Shot? Yeah, okay, good. Shot. Here you go. Shot. All right, we're making our way down. I need to see the 5-1 disc a little more than that. So please center it up. Yep. You can see the pseudo disc or fake disc down below. Show them that. Shot. Yep, right there. It's not a real disc. It's embedded in the bone in the sacrum. So it's truly, because the iliac crest runs through around L4-5, and the iliac crest is just above the disc we're operated on, truly that would be a lumbarized S1 in my opinion. But you could call it a sacralized L5. So just giving you some technical information. Shot. All right, we're passing the dilator through the tear where the herniation came out. So remember, for a herniation to happen, you need to have a tear in the annulus fibrosus. And the tear in the wall stays there the rest of your life until you get it repaired. And the only surgery that repairs it is this surgery, Duke laser disc repair. There's no other surgery that repairs the annular tear. And the way you repair the annular tear is first by debriding it. It's called a debridement. And that's what we do during the surgery, is debride it. Of course, the repairing is the body's healing it, which the human body can heal an annular tear once it's been debrided. All right, we're done. That went in pretty easily because the tear is pretty big. Once I debride the tear with the laser, then the disc will heal itself. And what's healing is the annulus. The nucleus doesn't ever regenerate. People ask me that all the time. But the nucleus pulposus never grows back. You're born with that amount, and what it is it's the notochord from the embryo, from the first phase of gestation, the first trimester. Whoa. Yeah. Everybody knows what an embryo is, I imagine. It's when the sperm and the egg come together to make a human being. Then you got 9 months in a human of gestation. Right? 9 months. My dad was an OB-GYN, but my OB-GYN is not that good. My embryology is not that good. But during the first 3 months, which are first trimester of gestation, again, there's granulation tissue. You see that?
Yes, we do.
Why don't you get a picture of that? Let me see if I can sharpen it up a little bit. That's probably the sharpest I can get it right there. Get a picture of that. And save that for Arius and our paper. These are just, this patient happens to have really good granulation tissue in his disc that are painful. So, also send that to Carl. Can you do that? Can you send these to Carl as well?
Copy that.
You see how the laser just zapped that stuff away so easily? There's no other tool that can remove the granulation tissue but the laser. Lasers. And I have an idea. Dolphins with lasers. What do you think about that, Henry? Dolphins with lasers?
I believe Austin Powers already did that.
Yeah, Austin Powers would like
he
that.
did sharks, right? You can do those.
Huh?
He did sharks, so you can do those.
Sharks.
Yeah.
Yeah, okay, he did sharks. Sorry, I thought it was dolphins with lasers. Sharks with lasers? All right. This is the tear, by the way. The blue stuff is the herniation stuck in the annular tear. Probably 5 minutes on this disc, doctor. Then we got one more to go. We'll be done. For those of you watching, our next surgery is going to be another Duke laser disc repair. And he's the staged surgery, right?
Yeah, stage 2. Yeah.
Stage 2. So basically, some patients come here with so many herniations, we can't do them all at the same time. Our limit is usually 5. 5 spots. This patient had 7. So we decided to break the surgery up into 2 surgeries, and we're going to be doing the second half of his surgery next. Now, I saw him after his first surgery, and he was so happy. His back pain was completely gone. He's had it for 30 years. We actually did his surgery this week on Tuesday. If you go back and watch, it was a 4-level, L2, 3, 3, 4, 4, 5, 5, 1 right side. And we're going to go to the left side and fix the herniations on the left side with this neck surgery.
I saw him at the clinic. He looked really happy.
Oh, he's so happy.
When he was walking, he was so comfortable.
Yeah. That's an important thing to talk about too. The disc is the source of pain. Well, 85% of the time. Okay, now we're doing a study soon. We're going to publish all patients that come in with back pain and what are the causes of their back pain. What's the most common, second most common, etc. And but based on my calculations, without objective data analysis, it's around 85% is, can you get a picture of that too?
Copy that.
That's just the tear. 85% of back pain comes from the herniated disc, the disc injury. But we're going to have actual tabulated data soon, as long as we do our project properly. Anyway, this next patient has leg symptoms on the left, and we're going to be treating him because of the leg symptoms. Okay, the back pain's already gone. What I was going to say earlier, though, is it's important for people to understand we're fixing the source of pain in the back, which is the disc. But remember, if you're having disc pain for years, it changes your whole life, and it changes the way you walk, the way you stand. It changes your activity level. So muscles get weak, and muscles get weak because you're not using them. There's an old saying, if you don't use it, you lose it. And they're talking about muscles and joints. So muscle and joint health has to be rehabilitated after these surgeries, because a lot of the people that come to us have chronic pain for so long, they haven't really walked normally, stand normally, exercise normally. They haven't put their body through the paces. And so they may have some aches and pains afterwards coming from muscles or joints that just haven't been used in years. And that's the only way to get rid of that is therapy, and reconditioning of your muscles and joints. That's why for some patients who are really deconditioned in the muscles and joints, the therapy is so important. And all their muscle and joint pain, I'm not going to fix that with this laser surgery. That takes time. It takes time in healing and reconditioning. So yes, this is an amazing surgery in that it gets rid of their back pain source, the disc, but it doesn't fix muscle pain. That takes reconditioning and therapy. Now, the best exercise people can do after the surgery is walking. And I have all my surgery patients walking the same day. So this patient's going to go home about an hour after surgery is done. So it's an hour recovery, and then the patient will go back to his hotel and he will recover. His wife is here to help him, but basically I expect him up walking around later today, going for a nice walk. My patients ask me, can I go to the beach and go for a walk? Absolutely. The beach is just 10 minutes away from here. So you're welcome to go to the beach and go for a walk. All right. Just about done. 1 minute left on this disc. How is he doing? Okay, good.
Great blood pressure.
Thank you. Yeah. The almighty blood pressure. All right, just about done. Any questions from the audience?
Yes, we have 2 questions. This first one comes from Doug Dean on YouTube. And,
Hi, Doug.
and they asked, is anyone currently suffering from a herniated or bulging disc that's not a candidate for your surgery?
That's a great question. Is anyone currently suffering from a herniated or bulging disc that is not a candidate for this surgery? No. Every single person is a candidate. Now, you may say, what if they're really fat? We've gotten fat people on the operating table. If they're really like super, super, super overweight, then it's hard to, we can't do it, okay? Because these instruments right here, they're made to be used in a certain depth, right? They're fixed. They can't be made longer. We don't have longer ones. So the biggest patients we've done are around 400, what, 450 pounds? 400? Yeah, about 400, a little bit over 400 pounds we can do. But if you're like 600 pounds, we can't do that. It's too big. So that would be a restriction, like, you know, over, say, 450 pounds. And then there are some rare cases where the arthritis of the facet joints in the back of the disc is so bad that blocks the needle from getting into the disc. And that's super rare, but it does happen. And that would also not be a candidate. So if you take 1,000 people with herniated or bulging discs and back pain, 999 of them would be a candidate, just, you know, based on the relative frequencies of morbidly obese that's over 450 plus the severe facet arthropathy. What's wrong? What's wrong? Oh. All right, so great question, and it shows really good understanding of what we're doing. We are fixing back pain that comes from a herniated disc, bulging disc, degenerated disc, slipped disc, protruded disc, ruptured disc. I mean, there's so many names for the same dang thing. And it's so confusing. I wish that radiologists and doctors would use one terminology, and that would be herniated disc, because they're all disc herniations. Are we ready? They're all disc herniations. Okay, they're all disc herniations. And the only one that's a little different is a degenerated disc, which is sort of advanced kind of collapsing and arthritis of the disc. Advanced arthritis of the disc is a degenerated disc, otherwise known as spondylosis. Spondylosis. So, but even with the degenerated disc, let's do some num-num. The source of pain is the same. It's the annular tear. Yeah. Are you blaming the blood pressure on me now? I understand. I like it. I like it. The problem is normotensive is too high. When you're sedated, normotensive too high is the challenge. Right. Well, what do you mean? When you're sedated, it's usually hypo, right?
No, when you give medicines, they're not as predictable when you're sedated.
Huh?
When you give blood pressure medicines to a sedated patient, they're not as predictable.
They're not as what?
Predictable.
Really?
Yeah.
Why?
Because anesthetics have vasodilatory properties.
Oh, well, that is a blood pressure medicine then.
Synergistic reaction that you
I see. I see. I thought it had to do with level of consciousness, but you're saying it's the anesthetic agent.
has to do with pharmacodynamics.
Shot? See, there are things I still have to learn. All right. You can take the guide wire out. We're doing what I'm calling the L4-5, but other doctors may call the L3-4. And it highlights an important thing in spine surgery. You know, you've got all these discs there. You could accidentally operate on the wrong one. And that does happen in spine surgery. It never happens at Duke Spine because we're extremely cautious about it, but also we have the best equipment to we call it localize, which is to count the right discs, basically. Okay? So show them the sacral disc, the bottom disc. We're going to show you this pseudo disc, the fake disc, all right? It's really, no, that's not it. Down, right, up, there. It's really hard to see on an x-ray. Why? Because the pelvic bones and the hips are in the way, right? So it's really hard to see. You guys see it there? Show it. Put the arrow on it. That's the fake disc, okay? But here's the deal. We have literally the best fluoroscope in the world, and that allows us to see it. Now, if you have a cheap fluoroscope, like most doctors buy, this one costs $170,000. A lot of doctors can't afford $170,000. They don't want to spend $170,000. I don't want to spend it either, but I do it because it gives me these pictures that are the highest quality and allows me to see the details I need to see. But a lot of pain management doctors, for example, they buy cheap, used, garbage fluoroscopes, and you can't see that detail. So they end up not seeing that disc down there, and they end up putting the treatment to the wrong disc. Happens all the time. Happens all the time. And not here at Duke Spine, but elsewhere. So you wonder, a lot of the reasons patients don't get better is, number one, the wrong treatment, but also the wrong equipment, the wrong supplies, the wrong drugs. Cheap, cheap, cheap. And as the insurance companies keep cutting the payments down or not paying at all, doctors are faced with making choices. Do I go cheaper on my supplies, go cheaper on my equipment, go cheaper on my staff, or do I go out of business? And of course, they didn't go into medicine to go out of business. So they end up making these decisions that I think are wrong. My decision a long time ago when the insurance companies were cutting was to say, I'm not going to compromise quality for payment from the insurance company. I'm going to basically have a talk with the patient and basically go out of network. Because if you're in network, the insurance companies force you to accept their payment and you're not allowed to charge more. So you're basically going to go out of business. Well, I felt it was more important that Duke Spine Institute stay in business than go out of business, even though the insurance companies would love for us to go out of business, because one less provider means less bills to pay, more profits to make. The insurance companies truly want you guys to pay your premium every month and then never see a doctor and never go for medical care. Brain tumor? No problem. Just put some ice on it. You have narrowed arteries in your heart? Oh, just take some turmeric, aspirin. You know, forget about getting it fixed. They don't want you getting anything fixed. And for me as a doctor, knowing that fixing is better than aspirin for a brain tumor, going in and taking the tumor out, that's better. And seeing that the insurance companies are blocking that, I realize that the insurance companies are not helping people. You know, the idea of an insurance company originally was to spread risk. What spreading risk means is if there's 1,000 people and we know that out of those 1,000, 500 will never go to the doctor, but the other 500 will, and out of those 500 that will, maybe 5 of them will have expensive problems that require surgery. The insurance company takes the money from all 1,000, small amount, and pulls it together and then pays for the people who are sick. That's the whole idea of an insurance company. It's like a kibbutz. But the insurance companies, instead of taking care of the sick people the way they're supposed to, they've hoarded the money, not paid it out, and they try to make the doctors and hospitals look bad by saying that the recommended treatments are experimental, okay? And the only reason they can do that is because they have politicians paid off, all right? So basically, the insurance companies are the most evil entity in the world today because they're lying to people that are sick and they're taking their profit over fixing those sick people. And that's diametrically opposed to my philosophy and belief. And since I'm the founder and owner of Duke Spine, I'm going to fight that. And I'm going to educate people about the truth, about what's really happening with their insurance and with their spines. Because if I was debilitated with back pain, I would want somebody to tell me the truth, how to fix it, okay? And you're not going to get that from your insurance company. You're not going to get it from your doctors, because the doctors don't know. And the doctors are too busy trying to make money doing more expensive surgeries like fusions. That said, we have one fusion coming up. When is it? Next week or the week after? We do have a patient who has 2 bad discs in her back, and we offered her laser, but She said, no, I'd rather have a fusion. Sorry, I shouldn't be laughing, but I tried explaining the difference, but she's dead set on fusion. So anyway, we're going to be doing a fusion here, lumbar fusion, L4-5, L5-S1. And that's going to be in the next couple of weeks. So look at our schedule online. Henry has been posting the surgeries, I think, the week before. And that way you guys can know what's coming up. But we're going to be doing an open fusion. It's called a TLIF, T-L-I-F. Stands for transforaminal lumbar interbody fusion. It's the best fusion you can do in the lower back. It is the absolute best technique. And there's lots of other techniques. But we've been doing TLIF. I've been doing TLIF for 26 years. And I've done 1,000. Here at the Duke Spine and Surgery Center Vieira, we've done hundreds of them right here. And we broadcasted them. Back in 2014, 15, 16, 13, 14, 15, 16, we were doing them, a lot of them, every week. And we broadcast all of them. So you can go on YouTube and find them. Or you can just come next week or the week after when we have it and watch it. All right, so this is the tear, and I'm debriding it. This is called an annular debridement. I've been doing this now for the last, 10 minutes on this disc? We're almost done. We have about 5 minutes left of this debridement. People say, well, what are you doing there? I'm debriding. I'm cleaning out the junk that's keeping this disc from healing and that's causing all the back pain and leg pain. All right, I know we have another question, right? At least one.
We have two, and they both come from S. Dell on YouTube.
Hello, Estelle. Welcome to our broadcast.
First question being, hello, Dr. Duke. Do you use drain to prevent post-op hematoma?
Do I use a drain to prevent post-operative hematoma?
Correct.
All right, not with the endoscopic surgery. There's no need for a drain. However, with the fusion, yes. I will put a drain. You'll see it in 2 weeks whenever we have it. I will put a 7mm JP drain, Jackson Pratt drain, for one night with the TLIF. I use a drain on two types of fusion surgery, posterior lumbar fusion and a posterior cervical fusion. I don't use the drains on ACDF. There's no need. I've done 1,000 ACDFs. I've had one hematoma in 26 years, and that was before I started coagulating at the end, the little veins and arteries that were in the retropharyngeal fascia along the spine. But once I started bipolaring those things at the end of the surgery, I've never had a hematoma. I had one hematoma my entire career in the front of the neck from an ACDF. That was back in 2004, so 20 years ago. And I've never used drains. I don't think it's necessary with ACDF, but with lumbar fusions, yes. If it's an open fusion, I use a drain. Just about done. Just another few minutes. We're almost at the back of the disc. There's the back of the disc right there. You can see the soft tissue fibers change. There's the fat. That fat is in the epidural space behind the disc. That's how I know. This is a herniation right here that we shoved back into the disc. Remember, we put the dilator in through the annular tear. That's the herniation. So I'm zapping it down into little pieces, and the little pieces are floating up and out. Estelle, I think, is a surgeon, right?
I believe so.
Where is he in India? He or she?
I would also believe so. They have not.
Estelle, where are you? Are you a surgeon, spine surgeon, and where do you live? I think you're in India, if I remember correctly. Maybe Bangladesh?
I think it was Bangladesh, but until then, they do have a second question for
Sure.
Estelle, and they ask, Dr. Duke, which position do you prefer, prone or chest knee position? What are the advantages of your choice position?
All right. Estelle, once again, I need to know what surgery you're talking about. Are you talking about a fusion, or are you talking about Duke laser disc repair endoscopic?
He is an orthopedic resident from India.
Ah, very good. So if you're talking about a fusion surgery, a TLIF, you never want to do chest knee ever, because you're putting a lot of intra-abdominal pressure, and that's going to cause bleeding from Batson's plexus. 1 minute. But if you're talking about my laser surgeries, we use a prone position and surrender.
That's
With
what he's
the-
talking about, the DLDR.
Yeah, this is a prone surrender position. And Luis knows the most about, we're using what, the regular 3080 bed?
Yes.
Using a regular operating table. We don't use, apparently we don't use the Jackson table unless the patients are big, really big. All right. See the epidural fat at 12 o'clock. I just want to get a little more of this herniation. 1 minute, we should be done. Great questions, Estelle. Thank you for asking. See how the laser is good at hemostasis? Stops the bleeding from the veins, or arteries, actually. It does that through coagulation of the tissue. This laser is amazing. Not only does it cut precisely, but it also stops any little bleeding and cauterizes, coagulates. Phenomenal tool. My favorite tool in medicine now. What's my other favorite tool, Luis? Yeah, I love the Kerrison. But for open spine surgery, it's the Woody. The Woody Woodpecker. So Woodson. It's actually they call it the dental tool because I guess dentists use it. But very commonly used in spine surgery. All right, just about done. 10 seconds. Let me show you, see if we can find the nerve root. Nope, it's buried in all that soft tissue. So, all right, we're done. Great job, everybody. You've done wonderful. I appreciate all your help. We did 4 discs, T12-L1, L1, L2, and then L4-5, L5-S1. Patient's doing fantastic. He is sleeping and starting to wake up. Now, if you have more questions, feel free to ask. I'm going to come and answer them for you face to face. I just want to say I saw an orthopedic surgeon doing a YouTube video, and his thumbnail has a woman in a bikini. And I thought, this guy's got it right. Maybe I should start putting women in bikinis. More people will watch my videos. I'd like to take a poll on that. Just kidding. My wife said, you're not going to stoop that low. I think she's right. Maybe we'll put Luis in a bikini.
Oh, maybe.
A Speedo.
That's what I usually do.
Yeah, you are wearing a Speedo, aren't you? Great job, everybody. Great job. All right, let's show the incisions, and then you can cut to a testimonial, and I'll come over there and answer. In the meantime, folks, type up your questions for me. These have been great questions today. We've got 5 surgeries. One of them is a DPR, right? Or are they all DLDR? They're all DLDRs? There is one DPR. So we're not going to broadcast the DPR, but we've got 4 Duke laser disc repairs we'll broadcast today. All right. You guys see this, Henry?
Yes, we do.
Those are our 2 thoracic area incisions. Here's our lumbar. And I'm going to call the blood loss 10 mil. That's the most we've had in a while. It's about 10 times normal. But it's funny, isn't it? 10 times normal blood loss, but it's still 10 mils. That's less than any other spine surgery out there. How's his lung fields? Good? Can you check them? Lung fields? If it's possible. Especially the left. Yeah, just mostly the left lung field. I want to make sure he's got good breath sounds there. All right, go ahead and cut to our testimonial, and I'll come answer your questions for you. All right, I'm here with one of my patients who traveled from Australia to Florida to the Duke Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone from
Awesome.
the disc. Yeah.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Duke laser disc repair.
I had the Duke laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Duke laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Duke. I found Dr. Duke, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L4-S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain about with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma. There's no scar tissue. There's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, you said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and their loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing towards others as well. And it's not only about you. It's also about your people living around you. That's very important. Yeah.
You came here for a purpose. You got your surgery that you had hoped to do. Now you're going to go back to Australia.
Yeah.
You got a long trip ahead of you coming up. And how do you feel about your experience here at Duke Spine overall?
Oh, it's really good. Staff is really welcoming, and it's spot on, and they receive you with a smile, and which is really great. And my father was telling, it's amazing how he never thought that in American health system people the clinicians are like this. So he was treated differently probably before while he lived in US, but it was really amazing, and your staff is really cool.
Thank you.
Yeah, they're welcoming. They're good.
Thank you very much.
And you are the best. I
appreciate it. It's an honor to take care of you, and it makes me feel so satisfied to see you happy and out of that pain. So congratulations.
Thank you, doctor.
You're welcome.
Yeah. If you're suffering from back pain, this is a very good cutting-edge technology and very advanced surgery, which Dr. Duke has developed his own, and without minimal, no damage to the bone, no damage to other things, and easily approaching to the disc and removing it. He is very skillful in reaching there without manipulating any of your muscles or anything, and you can see from me that I have recovered within few hours after the surgery. So I would say if you don't want a long-term complication from the surgery, this is the best surgery you can get done by Dr. Duke here.
Congratulations once
Thank you,
again.
doctor.
This is Dr. Aru Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Duke laser disc repair done and the Duke plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, you know, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well.
Yes.
And so what are you going to do now that you've had the surgery? And you could see actually the Duke laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
You know, the biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
Oh, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Duke's Spine Institute, Dr. Duke personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. R. Duke Majan with the Duke Spine Institute, and I'm here with one of my patients who just had the Duke laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Duke Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that, and nothing was really working. And then it eventually kind of got better, and then it would get worse, and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. The only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Duke Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody near us or anywhere near us that had any other option besides either getting a discectomy or a laminectomy or a fusion. There was just nobody was doing anything else. And I knew I didn't want to do that again because I'd already had that done. So it didn't work. And
Didn't work.
I had a really amazing physical therapist that connected me with you, and the rest is history.
Yeah, your physical therapist found us and was intrigued with the surgeries we're doing here
Yeah.
and sent you here. So what are you going to tell your physical therapist? I call him Dr. Salinas. What are you going to tell him when you...
Oh man, I've already told him. I texted him the minute I got back to our Airbnb. I said, I feel amazing, and I can't wait to tell all the rest of the patients in our Facebook group, like, this works. So.
It does. The Duke laser disc repair really does work. Well, is there anything else you want to say to your fans out there or friends?
My fans and my friends. Thank you for praying. Thank you for, believing me. I think that's one of the biggest things. There's a stigma around back pain because you can't see it, that people are just faking it, or maybe they're babies. Like, why can't you just deal with the pain? And it overwhelms you. And so to come someplace that believes me and then fixes the problem, and now I'm sitting here and I can be like a fully active mom. So I'm just beyond thankful. Thank you.
Yeah, chronic pain robs people of their dignity and their happiness and joy in life, and also their loved ones, the people that care about them.
Yeah.
Because they suffer with you.
Yeah.
Yeah.
A lot.
Well, congratulations and praise God.
Yes.
You found us.
Thank you very much.
And I think you're going to do fantastic.
I'm looking forward to being strong again.
Awesome. All right. Okay, welcome back, and we're just finishing up one of the surgeries, our first one for the day today on January 19th, 2023. This patient came to us with a history of debilitating back pain, of course, like most people, and it was coming from his upper back and lower back. It turns out that he had two herniated discs, and one at T12-L2, and then he had 2 more herniated discs in the lower back, causing his lower back pain at L4-5, L5-S1. We were able to get into both discs in the lower back and both discs in the upper back and fix them with the Duke laser disc repair. And he had 10 out of 10 pain when I tested those discs. That means those discs are so painful for him, and we just verified that in the operating room with that discogram. And he also told us that's where his typical back pain is. So we know we got the culprit. We fixed all 4 of them. Surgery went beautifully. Couldn't have gone better for him. You could see in the beginning of the surgery of the first disc, we had a problem where the tube was stuck on the dilator because some of the disc material got between them and wedged in there. So we were not able to take the dilator out, leaving the tube in, which is what we want to do. So we actually had to put a guide wire back in, take the whole contraption out, clean the disc out between the 2 pieces of metal, and then start over again. We lost about 15 minutes there, but in the end, it went really well. We got it done. I think he's going to do fantastic. He's from Georgia. As we've said before, about 80% of our patients are from out of state and out of country. They come to Duke Spine because we provide a type of surgery nobody else in the world offers, the Duke laser disc repair. All right, any questions, Henry?
Yes. Our first one comes from Doug Dean on YouTube.
Hello, Doug Dean.
And they said, a surgeon in Dallas said this regarding laser surgery, quote, they lack the adaptability to manage unexpected bleeding, a cerebrospinal fluid leak, or an unforeseen disc extrusion. How do you respond to that?
Well, it's a good thing we never had any of those problems. So maybe that surgeon needs to go back and relearn how to do surgery if they're having unforeseen disc herniations or cerebral spinal fluid leaks. We've never had a cerebral spinal fluid leak or an unforeseen disc herniation or the other issue. What was the first thing he mentioned?
They lack the adaptability to manage the unexpected bleeding.
Yeah, there is no unexpected bleeding. As you could see, there's no bleeding. The most blood we've ever lost was today, this surgery you just watched, 10 cc's. That's about 10% of what that surgeon in Dallas loses every single surgery he does. He's losing 100 cc's to 500 cc's. So all I can say is there's a fable from a writer named Aesop, and I suggest you look it up, Aesop's Fables. And there's a story called Sour Grapes. I recommend you read that story because that summarizes this other surgeon's opinion. Basically, when you don't have what's best, somebody else does, you've got envy, and so you're always going to say, oh well, what they have isn't that good anyway. The laser surgery is the very best in the world. 1,600 surgeries now, and we broadcast every week from beginning to end, and you can see there's no unforeseen bleeding, there's no missed herniations, and any other complications that he's talking about. Now, I will say this, Duke Spine Institute does the surgery the right way. That's why we don't have those complications. Other surgeons are sloppy, they don't pay attention to the details, so of course those types of complications can occur with other surgeons, but it has nothing to do with the laser, okay? It has to do with their incompetence.
All right, and the next question comes from Estelle on YouTube once more, and they asked,
Hello, Estelle.
which book should an orthopedic resident read for endoscopic spine surgery? There are many books, but please mention the most useful ones. Thank you.
You know, books are books. They're important. However, what's more important for endoscopic spine surgery is training. Actually going somewhere where you can learn the technique and learn it well. There's a tremendous emphasis over in India and Asia right now on what's called the biportal technique of endoscopic surgery. And that's probably the most popular around the world. I don't use that technique because it's, in my opinion, inferior to the technique we're using. We're using a uniportal or a single portal. They're using 2 portals. They're going translaminar, meaning they're removing the lamina and ligaments, which is bad. We don't do that. We're going transforaminal. So if you go transforaminal like I do, it's the very best technique there is. And unfortunately, it's the hardest to learn, it's the hardest to perform, but it's also the very best in terms of outcomes, safety, and it doesn't cause any collateral damage. So the biportal technique does cause damage to the patient and their normal spine. I'm not sure how to advise you on this, but my advice to you would be find the very best surgeon you can train under and spend a year doing a fellowship in endoscopic surgery.
And that is it.
All right, thanks for joining us. The questions have been excellent today and somewhat entertaining. Feel free to join us for the next surgery. It's going to start in about 30 minutes. And Henry is going to find out when we're doing that fusion on the lower back. I think it's in the next couple of weeks. So if you're interested in watching a Duke spinal fusion done, which is a T-lift procedure with osteotomies, this is an outpatient surgery. Our patient will go home. It's a 2-level fusion, L4-5, L5-S1, with instrumentation, interbody cages, interbody fusion, and Smith-Peterson osteotomies to decompress the neuroforamen, and posterior lateral arthrodesis as well. All of that will be done open. It will be done outpatient. The patient will go home 2 hours after the surgery, walking. So if you want to see that surgery, look for it on our live stream schedule. Thanks so much for joining.